Today, we are diving deep into the story of the very first drugs that were designed to treat psychosis. Before these came along, the options were, well, they were pretty grim. These medications completely changed the game in psychiatry, but they came with a really complicated and challenging legacy. So let's get into it and explore how they reshaped mental health, for better and for worse.
Okay, so imagine your brain as this giant, super complex communication network, right? You've got billions of messages flying back and forth every single second. But what happens when some of those messages get way too loud, distorted, or just completely scrambled? That's the exact question that kicked off the search for the drugs we're talking about today.
So, antipsychotic meds basically fall into two big groups. You have the typical, or first-generation drugs. These are the OGs, the pioneers we're focusing on. And then you've got the atypical, or second generation, which came later. The real difference between them is how they work and, crucially, the kinds of side effects they cause. We're going to stick with the originals today because their story, the good, the bad, and the ugly, really laid the foundation for everything that came after.
All right, here's our game plan. First, we'll talk about the problem itself, psychosis. Then, we're going to get into a little brain chemistry with the dopamine story. After that, we'll look at the drugs that block dopamine, the side effects that come with that, and finally, what good patient care looks like. So let's start at the very beginning. What exactly is this condition that these powerful drugs were invented to treat?
Psychosis is basically a state where a person's brain is having trouble telling the difference between what's real and what's not. This can mean seeing or hearing things that aren't actually there, those are hallucinations, or believing things very strongly that just aren't based in reality, which we call delusions. This is the main target of these medications.
And you'll see these drugs used in some pretty serious situations. They can be for the long-term management of conditions like schizophrenia, but they're also used to handle acute episodes like calming someone down who is severely agitated or in a state of mania. The main goal is always to try and bring some sense of order back to a very chaotic inner world. Now, to really get how these drugs pull that off, we need to zoom in on one specific chemical messenger in the brain. So let's dive into the dopamine story.
You've probably heard of dopamine. It's one of the brain's superstar neurotransmitters. It's a huge player in how we feel pleasure, what gets us motivated, and our ability to focus. But, and this is the important part for us, it also helps shape our perception of reality. The leading theory for conditions like schizophrenia is that the dopamine system is overactive, and that's what's contributing to things like hallucinations and delusions.
The easiest way to picture this is with a simple lock and key analogy. Think of a dopamine molecule as the key. It floats around in the brain, looking for its perfect match, the dopamine receptor, which is the lock. When that key slides into the lock and turns, click, a message is delivered. That's the system working just like it should.
So, if the problem is too much dopamine activity, too many keys finding their locks, how do you stop it? Well, the strategy of these first-generation drugs is pretty blunt. You block the lock. The drug is like a key that fits in the lock but then breaks off, jamming it completely. Now, the real dopamine key can't get in. The message gets interrupted, which effectively turns down the volume on that overactive dopamine system.
Okay, so let's get specific. Let's look at the actual tools, the drugs themselves that do this blocking, and how that leads to a therapeutic effect. Here are some of the classic names you might hear. Drugs like chlorpromazine and haloperidol were absolute game changers back in the day. They offered real, tangible hope where, honestly, there hadn't been much before. But here's the bottom line for all of them. Their main job, their core function, is to block a very specific type of dopamine receptor called the D2 receptor. It's a really simple idea, but it's incredibly powerful. By sitting in those receptors, they just lower the total amount of dopamine activity in key parts of the brain. And the result of that blockade? For a lot of people, it's a profound sense of relief. The voices, the paranoia, that overwhelming feeling of agitation, it all starts to quiet down. This is why these drugs were seen as miracle workers when they first came out. But this powerful effect doesn't come for free. Because when you forcefully slam the brakes on a major pathway in the brain, you're going to affect more than just your target. So now we have to talk about the other side of the coin, the unwanted effects. This right here is the single biggest issue with first-generation antipsychotics. See, dopamine isn't just about psychosis. It's also absolutely essential for controlling your movement. So when you block those D2 receptors, you can cause a whole bunch of movement problems we call extrapyramidal side effects, or EPSE. This can look like Parkinson's, with tremors and stiffness. It can be a horrible internal restlessness called akathisia, or even sudden painful muscle spasms.
But the one that everyone worries about most is tardive dyskinesia, which can cause permanent, involuntary movements like lip smacking or grimacing.
And it doesn't stop with the movement disorders. There's a whole list of other side effects. People often feel really sedated, just wiped out, which makes it hard to get through the day. They might get dizzy every time they stand up because their blood pressure drops. And then you've got those annoying, persistent things like dry mouth, constipation, and often significant weight gain.
So, given this really complex mix of incredible benefits and very serious risks, the way a person is cared for while on these drugs is absolutely critical. This is all about the human element.
You see, good treatment isn't just writing a prescription and walking away. It's an ongoing process. You have to be constantly watching for those movement side effects. Sometimes you even have to give other drugs just to manage the side effects of the first drug. You have to think about safety, like protecting someone from falling if they get too dizzy. Even simple things like encouraging them to drink water to help with dry mouth make a huge difference. And most importantly, you have to educate the patient so they know what to look out for and feel empowered to speak up.
Okay, so let's boil it all down. What are they used for? Treating psychosis. How do they work? They block dopamine receptors. What's the best part? They can reduce hallucinations and delusions. And what's the biggest drawback? That high risk of serious motor side effects. It's a powerful and often really difficult trade-off.
And that leaves us with the big, enduring question that really defines this entire class of medication. I mean, these drugs were revolutionary. They gave people the first real chance to quiet the storm of psychosis. But that power came at a serious price. And so the question, for doctors, for patients, for families, has always been this: how do you balance that incredible power with its profound side effects? It's a question that's still at the very heart of psychiatric care today.